I have been managing this type of patient. It's a coincidence that madam told me to discuss on this. So we will be discussing about this condition which was not clear. Even today also it's not very clear exactly what to do, how to manage this population. Normally, if I do one survey, we will find in about 38% of the population will be finding the symptoms or sign what we used to see in this condition. The next one is I wish all of us had a gut system like this, neat and clean looking like this, but unfortunately it is not that. Please don't get afraid of by seeing that picture. So this looks like one of those busy lanes of Calcutta. And do you have a pointer? So if you don't have a pointer, then it's fine. I will navigate you. Please try to understand because that is how I made it myself, just to understand and let you understand what is actually this condition. I will try to navigate you from here and then reach the top, and then you will definitely understand what I have made. So we have a GI tract starting from the mouth till the anus, of which inside the abdomen, the intestine part is the small bowel and the large bowel. The length of small and large bowel is 22 feet around, and 25 feet. And this small bowel is about 20 to 22 feet, and this is 3 feet. 95% of the nutrition or whatever we're eating are getting digested and assimilated or absorbed in this part only. And this is only for water, electrolytes, etc. So 5 liters of liquids or fluid or digested part which comes through this, enters into this, becomes 950 ml while coming out through the anus. Now, what is the second most important function of the small bowel is the immunological function. 75% of the immunological work of the body or the system of the body resides inside the small bowel. Now, this small bowel has, in fact, the entire GI tract, starting from the mouth till anus, is flooded with bacteria or the microorganisms which are called good bacteria. Now, we have some bad bacteria also, but it is predominantly the good bacteria which stops the growth of the bad bacteria and takes control of the situation. These bacteria has multiple work inside the body. I'm not going to discuss that. It's a very, very long topic. Now, what is their number? The talk is based on their numbers. Please try to understand. Let me start from the stomach. It is in the multiplication of the 10. If you'll find CFU, colony forming unit. That means one bacteria, one colony forming bacteria. One bacteria will form one colony. So inside the stomach, each dot, you please count it as, each dot could be 10. So the stomach has 10 bacteria. If per ml, if you take 1 ml of fluid, then I'll find 10 bacteria, 10 to 1000, commonly around 10 plus. Slowly, duodenum, it becomes doubled. It's about 100 here in the first part of jejunum, slowly increase 3 times. Then by the time it reaches the terminal part, it becomes 8 times. And then inside the colon, it is 12 times. So nearly 1 trillion, 1 billion to 1 trillion bacteria are there inside the colon. So don't be confused about so many, what are the names of the bacteria. So I have simplified this one. If you see from stomach till the colon, stomach, duodenum, small bowel, they have different bacteria, but the common bacteria to all the GI system is lactobacillus and streptococcus and others. This is other than the colon. They can be there in the colon, but they are the commonest bacteria inside this And in the colon, the commonest are the Clostridium and the bacteria, and of course others. So what does this do, and why there is lack of bacteria in the stomach? Because of the acid. So what does these bacteria do? They bacteria are normal commensals, and they perform certain functions in the body, and they live by probiotics, prebiotics. What are they? Mostly the fibers, the glucose, and all other nutrients except possibly protein and little bit of fat. They eat those things and survive. If by any means the number of bacteria goes than a certain level, they become detrimental to our body. Now, how? Why does it happen? Now, these overgrowing bacteria, which should be confining themselves to the small bowel, and these bacteria which should be confining themselves to large bowel, if they overgrow, they can go back to the small bowel. The small bowel bacteria could itself multiply to much higher level. Why that should happen? That should happen because of this. Suppose there is some obstruction here, or there is motility disorder in which the bowel movements are slow, or we do certain operations in which we have to shorten the bowel, or what we call as short bowel syndrome, or we call as blind loop syndrome. That means sometimes we accidentally leave longer loops through which the fluids do not go. That's we call as um, a blind loop syndrome. So in those cases, in which case, if the flow through the small bowel is not proper, and there is some stasis around the small bowel, the bacteria overgrows. It is just like, see this one. If there is a flowing water, so very difficult that you will find fungus in that. So similarly, so far as the small bowel transmits this bacteria by a good flow, obstructionless flow, the bacteria number will be maintained. If there is some obstruction to the flow in terms of surgery or in terms of infection inside the abdomen, wherein there are adhesion formation, means fibrosis, they will just, these loops will be adhering to each other and forming obstructed loops where there will be slowness of the movement of the digestive material. So these bacteria grow. What will happen? They grow to nearly 100 times. So when they grow, their function is to ferment the carbohydrate. So when we take carbohydrates, they ferment, and then they ferment, they form gas, and the gas, I'll tell you what are the gas, they pass through the circulation, and then they can go through the circulation into the lungs. From there, they can go to even the brain, or they can come out through the nose, through our breath. So fermentation passes through circulation, lungs, brain, and through the nose, through the breathing. Now, what are those fermentation gases? They will ferment to mostly two things. One is carbon dioxide, one is hydrogen, and their compounds. So the gases which are formed are called methanogens, then acetogens, if they form acetone, hydrogen sulfide, and ammonia. So these gases can be excreted through the respiratory system. So if you measure them, we can measure higher quantity and say that possibly there is bacterial overgrowth here. So the measurement is either you measure the hydrogen, or you measure the methane, or you measure the hydrogen sulfide. Earlier on we used to measure 2, now we can measure 3. So if you give the patient carbohydrate diet and then measure the breath, hydrogen, methane, and hydrogen sulfide, you will find them higher than normal. You can say possibly he has bacterial overgrowth. But why should we do all these things? Because when the bacteria will overgrow, they will form these gases. The patient will have distension of the abdomen. He will have nausea. He will have early satiety. You'll not have a desire to take food. And because of this, he will face fatigue, will not feel well, his quality of life will become bad, and all the time his mood will swing. Some people say that these gases or the toxins from this bacteria can act in the brain. They will have brain fog, means feeling like कि सर पता नहीं दिमाग में मेरा क्या हो रहा है, मैं सब भूल रहा हूँ, I am having mood changes. So all this could be because of this. So when these things happen with this type of symptoms, you can have bloating, nausea, discomfort, fatigue, constipation, diarrhea, and vitamin B12. Now I want you to remember the difference between the two. There are two type of things. One is small intestinal bacterial overgrowth, that is called SIBO, SIBO or SIBO in USA. So if it is methanogen producing organisms, so they are called small intestinal methanogenic overgrowth. So these methanogen producing organisms are actually not bacteria, they are bacteria like organisms which are called archaea. So in place of this, if there is fungal infection, fungal growth, fungus are also there in the throat, they can go inside. So there could be transmission of bacteria down or up. So if they come upwards down, they can form fungal infection inside the GI tract. So that is small intestinal fungal overgrowth. We will be focusing mostly this. What is the basic difference between SIBO and SIMO? Is this. If there is a small intestinal bacterial overgrowth, the patient will have diarrhea. If there is a small intestinal methanogen overgrowth, then they will have constipation. That is the basic difference between the two. So, what are the causes? One is surgery, one is adhesions, one is dysmotility, one is medications. Most common is the opioids, which reduce the motility of the gut and reduces the peristalsis. Some say it is because of the omeprazole, pantoprazole, lot of things which you are giving that reduces the acidity, so it can precipitate this. And it has been seen that chronic pancreatitis and reduction in immunity, that is the patients who are having immunologically deficient, like HIV, diabetes, chronic diseases, there also this can happen. Diagnosis, breath test, and the most direct diagnosis is by endoscopic aspiration, means put an endoscope here, go down here, take a sample and count the colonies. But this is more difficult process. You can go through this like through a colonoscope, go here, go reach there, take samples and count the colonies. Now this is the pathology, etiology of a small intestinal bacterial overgrowth or SIBO. Now let us go to the clinical aspect of this. If I tell the symptoms, I think half of us would say that we are having this. So if a patient, suppose a patient comes to us with these symptoms, sir bloating हो रहा है, nausea हो रहा है, discomfort हो रहा है, I am having fatigue, I am having joint pain, I am having body pain, body ache. First and foremost thing, as a physician, don't jump over to this. First we have to ask, do you do exercise? What is your lifestyle? Do you take good sleep? Do you take caffeine? If you are taking all this, first correct them and see whether you are recovering it from it or not. So once they do that, then we have the irritable bowel syndrome. You must know what is the difference between the two. Irritable bowel syndrome is a functional problem of the gut, almost having similar situation. And 40 to 50% of these cases of SIBO can be associated with IBS. Aim of the treatment, symptomatic improvement. Not here that I will reduce the hydrogen, reduce the methane, patient will become all right. No, the patient has to tell that, yes sir, madam, I am getting better with your treatment. There are 4 steps of treatment. One is treatment of the cause. That is, stop opioid means bring back his motility to normal, control the precipitating factor. The physician will control the inflammatory bowel disease, Crohn's or ulcerative colitis, celiac disease is a very common disease wherein this thing is precipitated, infections, diabetes. And then second part is to reduce the growth of the bacteria by giving antibiotics or giving elemental diet. So what elemental diet will do? Elemental diet doesn't have any fiber. It will get absorbed by the time it reaches here. Somewhere here the absorption will be finished. So it will not reach here. So no growth will occur. So that's why they say that the elemental diet should be tried. And is it probiotic? So after this, the real evidences you have to look for. Step 1. Now we have meta-analysis of 13 trials. It's the highest level evidence which says that if you give a low FODMAP diet, means like this one. This is a high FODMAP. I presume you know what is FODMAP diet. All of you know? Yes. So try this thing. Mostly the idea is monosaccharide, disaccharide, oligosaccharide, aldol, polyols. You just these four things you have to reduce the fiber, and then you get this type of diet. You have to tell them. The course is 46 weeks, not 10 days, 14 days or a month. You have to give 46 weeks, then reduce this because these are tasteless. Low FODMAP diet, if you give elemental diet, they are tasteless. Patient will not comply. Now then after that you can start slowly resuming the previous diet. You may get the desired result in these people. So phase 1, how to use low FODMAP diet? Phase 1, elimination. Avoid high FODMAP for a month. Then reintroduce phase. Systematically add the foods which you are taking, and then you check out what is suiting him more, or which one is causing him more problem. So this is about the FOD. Step 2, probiotics. You have meta-analysis of 15 trials which say that if you give 4 probiotics, lactobacillus, bifidobacterium, Saccharomyces boulardii, soil-based, these 4 has to be there inside the capsule to work, and then you will have 53% resolution only with probiotics alone, and the symptoms will be relieved. So you give low FODMAP and probiotic, there will be more than 40% resolution. Means if you give only this or you only do diet control, more than 10% more than that will be useful if you add these two. If this is not working, then you go for step 3. We give antibiotic. We have again a very good evidence. If you give antibiotic alone, 35% will be effective. If you give with probiotics, it will be 85% effective. And what is the best drug used is rifaximin. Rifaximin is a locally acting drug. It is never getting absorbed into the circulation, so it is mostly preferred. You have to give 3 to 4 months to this drug, 400 2 times daily. You can give this one, doxycycline, tetracycline, metronidazole as a substitute, but these are systemic ones, so not advised. One randomized trial has shown that herbal medicines, not medicine, herbal supplements like berberine, oregano, allicins are as effective as rifaximin. There are a lot of literatures on herbal coming up. So I'm not actually saying in favor of them, but this is what is mentioned there. Step 4, and I think it is most important from dietitian point of view, surgeon's point of view, you can only manage with this. These things are temporary, but this is what you can carry on for a very, very long time. Now, what about elemental diet? You have to give 14 days, you will find if it's effective. Then slowly you have to change it. One time elemental, one time polymeric diet. Like that, then only he will comply. Otherwise, they will not comply. They are absolutely tested. Till now, no testy elemental diet is available. There is a research for you. So, elemental diet, FODMAP diet, you have tried, nothing working. You can add prokinetics to that. We have trial, but not very strong evidence that only one paper which says that if you give erythromycin with PPIs, means the pantoberazoles or lansoparazoles, then it tends to work better in these conditions. But the most important is the food habit and the lifestyle of the patient. So in summary, it is a diagnosis of exclusion. Never ever jump to diagnose SIBO in a person who is complaining these particular symptoms: gas, bloating, nausea, body pain, joint pain, etc. First step is see that he might be having some lifestyle problem, correct that diabetes is there or GI tract problem is there, exclude that, then exclude IBS, irritable bowel syndrome, by various testing are there, endoscopies, colonoscopies and other workups. And after exclusion, give a trial of therapy. First trial of therapy you have to give is diet. And that is where your job comes for. And I think most of my patients have been very successfully managed. The headache has been taken over from me by our nutritionist. So you can really manage all the four aspects except the antibiotic part, and it must be differentiated from IBS. Symptoms can be mild to crippling. 60% of these people, they do not have any symptoms. 40% out of 40%, another 20% or 25%, they are mild. But if it crosses about 3 to 4 months, it could be really crippling, and particularly psychological, they may go into depression. And most of the people will have antidepressant drugs when you find them in your OPD. Breath test is the commonly used diagnostic test, not the endoscopic or the colonoscopic one. Management includes a stepwise multi-team approach. The nutritionist, they play a central role in the management, as I said, and you should counsel the patient very well. Possibly this is the most important line in the entire management system, that you may have to live with it. It will recur. The chance of recurring is 63% with every year or every 6 months. You have to explain. Strictly follow a lifestyle, be in touch with us, strictly watch your diet, and periodically take antibiotics. You will be symptoms free for about 80% throughout your life. Mild here and there, he can manage very well. So that's all. Thank you.